Well, welcome everyone. Today I'll be having a conversation with Dr. George Delgado, medical consultant to the Abortion Pill Reversal Network and the founder of the Abortion Pill Reversal Network. We're going to talk about abortion pill reversal, why it's important for this era in history, how it works. Dr. Delgado is going to respond to some critiques and also talk about how medical professionals can help provide APR to women who need it. Today, we live in a rapidly shifting post-Roe medical environment. Abortion pill reversal is proving to be an important component of our fight to provide life-affirming medical care to women facing difficult pregnancy situations. As medical professionals, it's more important than ever that we know about the use of progesterone and abortion pill reversal, what it does, and how to use it to serve our patients. Some housekeeping things. This webinar will be recorded, and the recording will be sent to you all shortly after this event for review. Send it to your friends who couldn't make it. Keep an eye on the chat, as we'll be posting resources throughout the event that may be helpful to you. If you have questions during the event, please write them in the chat. We'll try our best to get to all of your questions, but if we can't, we'll be sure to address them in future webinars. Now, because of so many people and the popularity of this webinar, there is a high chance that we won't get through all of your questions. We do recommend you check out our website, www.aplog.org, and go to the resources section for practice guidelines, committee opinions, and numerous statements on various issues that might be helpful to you. You can also email us at communications@aplog.org. or reach out to us on Facebook, Instagram, Twitter, or LinkedIn with any further questions. Our social media handles are @APLOG for Twitter, @APLOG, that is AAPLOG_ for Instagram, and @ProLifeOBGYNs for Facebook. Now let me get to my introductions. I am Dr. Donna Harrison. I'm a board-certified OBGYN and CEO of the American Association of Pro-Life Obstetricians and Gynecologists. I have been active in APLOG since 1996. I practiced obstetrics and gynecology in a multi-specialty practice for 10 years after residency, before shifting to research and administration in APLOG. I've authored numerous peer-reviewed papers on topics such as the approval of RU46 and on olapristal, which is Ella, and defended many state laws requiring information to be given to women on abortion pill reversal before undergoing a chemical abortion. I'm an adjunct professor at Trinity International University in Deerfield, Illinois, and an associate editor of the peer-reviewed medical journal Issues in Law and Medicine. And I am delighted to be able to have on the program tonight Dr. George Delgado, who I've known for several decades. Dr. George Delgado is the president of the Steno Institute. He's a medical consultant to the Abortion Pill Reversal Network, and he is the founder of the Abortion Pill Reversal Network. He is board certified in family medicine and in hospice and palliative medicine. He published one of the first case studies in the peer-reviewed medical literature describing the reversal of mifepristone, that is RU46, using natural progesterone. He then established the Abortion Pill Reversal, a program that connects women who have changed their minds after taking mifepristone, that is RU46, the first drug of the abortion pill regimen. Women who have changed their minds and want to reverse the effects of that first drug, the first abortion pill. APR also seeks to refine and improve the treatment protocols for reversing mifepristone. Dr. Delgado and his wife have 4 children and 1 grandchild, and welcome, George.
Thank you so much. It's great to be here.
George, I have some questions for you that were very popular questions that many people want to know. So I'm going to just start out with the most popular questions, and then we'll work our way down through the questions. So first of all, why is it important right now that physicians and pro-life advocates know about abortion pill reversal right now in this post-Roe era?
Well, of course, it's very important because there are women out there who start the medical abortion process and change their minds and they want a second chance at life. And the numbers are increasing. The number of calls to the hotline are increasing. And even before Roe v. Wade was overturned, we were seeing a trend, like in many other countries, away from surgical abortion to medical abortion. And we've seen that gradually since mifepristone was introduced in the year 2000. So that just a few years ago, we were up to maybe 35 to 45% of all abortions being medical abortions. And the vast predominant one, of course, is mifepristone. Well, in running up to Roe v. Wade, we saw a growth in telemedicine abortions under the auspices of loosening of COVID because loosening restrictions on mifepristone, and also an increase in telemarket and mail order mifepristone. So women can just type in a few little symptoms and a few data points and get mifepristone mailed to them. They also can go online and see a practitioner virtually and get it mailed to them. And we saw the run up because the abortion people were scared that their means of getting abortions was going to be decreasing. And now what we're seeing, of course, are that certain states are establishing themselves as havens for abortion. New York State, Illinois, and California in particular are recruiting women to come and visit them in order to get their abortions. So we're going to see this more and more women are going to be starting medical abortions. Many of them are not going to have good informed consent procedures. They're going to make hasty decisions, and so they will change their minds. We need to be there for them in order to offer them that chance to reverse their medical abortions.
Well, that's really important, especially as we gear up for this era, to be there for the women. And that's what you have always said, that is the purpose of the Abortion Pill Reversal Network. So let me ask you a question. Patients are often told by their abortion providers that a medication abortion is not reversible, and we're saying that it is. So can you elaborate on how medication abortion reversal works and how effective it is to reverse the effects of mifepristone?
Sure. Well, first of all, this advice they're getting is either from people who have not read the medical literature or who are simply lying. Don't know which one it is. It's probably both of them. And I think part of that is because it really brings into question their rhetoric and their mantra that abortion is good for women. Because if some women change their minds, then it's obviously not good for those women. So I think that's one of the reasons why they're telling women they simply can't reverse it. But it is reversible. And we know that mifepristone is a progesterone receptor antagonist, and that's how it works. And progesterone, like the name implies, progestation, it's an acronym because it's essential for pregnancy. We know that progesterone has many functions that are essential to a normal pregnancy, including keeping adherence of the placenta to the uterine lining very tight, as well as causing the uterine muscle to relax and keeping the cervix very closed. And when you have a withdrawal of progesterone or withdrawal of the progesterone effects by blocking the receptors, then you have separation of the placenta and you have the medical abortion that takes place. When you block that action by outcompeting the mifepristone at the receptor sites, which is what we do by supplementing progesterone during this critical phase, well, what happens is it's like you have different keys lined up in front of the lock. Some of the good guy keys, they open the lock and open the door. Others simply go into the lock and block the lock. Those are the receptor blockers, the antagonists. Well, if we have more of the good guy keys in front of the lock, we're going to win that race. And this has been shown in multiple enzyme and hormonal systems that one molecule can outcompete the other by simply being there in a higher concentration.
Yeah, that's right. And it's really basic biochemistry 101 and competitive inhibition. So I'm really glad that you explained that, and the fact that progesterone is a normal, natural hormone. We're not talking anything artificial here. So
right. Okay, using bioidentical progesterone, which is molecularly exactly what the woman's body produces. So we feel that it's safe, and progesterone frankly has a 50-year track history of safety in pregnancy. It's been used for years and years very safely. The IVF doctors, they routinely put their patients who are pregnant on progesterone for the first trimester. They feel very confident that it's safe. We feel very confident that it's safe. The medical literature supports the safety of it.
That's really important to know. Now, critics of APR claim they throw around this term junk science, not backed by high quality studies. But you and I both know that that's ridiculous, having looked at the medical literature. So can you explain to everyone why this claim is just patently false?
Sure. Before I go into the three pillars of support for this, I just want to make an analogy that I think will really ring home truly to people, that anytime we have a new medical breakthrough, we start off with simple studies, usually observational studies, and then we build our way up. So that's why I call this new science and not junk science. It's because it's new. And look back at another life-saving treatment, and that's called CPR, cardiopulmonary resuscitation. There was never a placebo-controlled, randomized controlled trial with CPR. No, once they discovered that it worked, then they went forward and just tried different types of CPR, comparing those to one another, never subjecting people to a cruel placebo of just standing by and waiting to see what would happen if no one did CPR on you after your heart attack, right? Well, the same thing goes with abortion pill reversal. Now that we have a proof of concept that we know that progesterone can reverse the effects of mifepristone, well, it would be cruel and it would be unethical to conduct placebo-controlled trials for that. But nonetheless, we do have three areas of pillars of support. First is animal research, where placebo-controlled studies actually were done. And in those animal studies, we know that a group of pregnant rats that were given mifepristone only aborted all of their pups, while a group of pregnant rats that was given mifepristone plus progesterone either didn't abort any of their pups or, depending on the dosages, aborted far fewer. And when they did histologic examinations on those rats, they did necropsies, they found that the histologic changes that occurred both in the uterus as well as in the ovaries with the mifepristone only did not occur in the group of rats that got the progesterone along with the mifepristone. They're very much in an animal model proving that progesterone reversed the effects of mifepristone. Then we have our studies. Besides our first study that involved 6 patients, we conducted a large observational case series of over 250 successful reversals of mifepristone abortions. And there we found that with our very best protocol, 68% of the babies survived, either to late pregnancy or to birth, depending how long we were able to follow them. And this was much better than what we used as our placebo rate, which is a historic control rate that we obtained from a study conducted by Dr. Mary Davenport, one of my colleagues, and also involved with me at the Steno Institute, where she looked at all of the early mifepristone studies before they added misoprostol and found that the best survivals there were about 25% if the patients got mifepristone and nothing else was done, and they observed them. They only observed them for a few short days, and we know that often mifepristone takes longer to work than just a few days, maybe even up to 10 days. And so probably that 25% survival is an overestimate, but we wanted to be very conservative, and so we use that 25% rate. So we have that human data. We also have the human experience now going on with Heartbeat International, which now is running the Abortion Pill Reversal Network, where we find that more and more women are taking advantage of abortion pill reversal. And there have been documented over 2,500 births after successful reversal since our study. So that's great data right there. And finally, we know that it makes biologic sense. We talked about, I mentioned briefly that whenever you have a hormone system or enzyme system where you have 2 molecules competing for the same receptor, you adjust the concentration of one, it will outcompete the other one. And that's been shown time and time again with enzyme systems and with other hormonal systems. So it makes biologic logic that this would work.
Yes, and I want to add too, in the drug development literature for mifepristone, there was actually a study just like that, looking at the PK, the dissociation constant for mifepristone, RU46, it's all the same drug. Looking at the dissociation constant in the presence or in the absence of progesterone. So they know exactly how progesterone can dissociate mifeprex from the receptor. So there's all kinds of evidence for this if you're willing to open your eyes and look at it. So another claim that APR critics make is that the procedure is dangerous for women, or that failing to complete a medical abortion will cause birth defects. Why do they say that, and why are they wrong?
Well, again, I don't know why they say that. It's either because they're ignorant of the literature or they simply are being deceptive, but that is totally untrue. When you look at the 2 drugs to which the baby's exposed, we already talked about progesterone has a 50-year track record of safety, of not causing birth defects. The FDA came out with a statement declaring that progesterone is not associated with birth defects, particularly not associated with hypospadias in male infants, because certain progestins, such as medroxyprogesterone acetate, are associated with hypospadias if the male infant is exposed to it in utero. So we know that the progesterone is safe. How about the mifepristone? Well, we know that APLOG has come out with 2 practice bulletins, the last one in 2021 on medical abortion. And in there, they state that there's no evidence of teratogenicity for mifepristone, i.e. there's no risk of birth defects known with mifepristone. So it appears that mifepristone, since it acts on the placenta and not on the preborn baby, him or herself, that it simply can cause death by causing separation of the placenta from the wall of the uterus, but not causing birth defects. And then we have our case series, which is now the largest case series of embryos and fetuses exposed to mifepristone and also now exposed to progesterone in the medical literature. And our birth defect rate was 2.5%, which is equal to the expected birth defect rate, which is usually quoted as between 2 and 5%. So we're very confident that mifepristone and progesterone do not cause birth defects either by themselves or in combination. We also did not find any increased risk of preterm labor. In fact, in our large case series, the preterm birth rate was lower than the national average of 10%. It was actually 2.5%, probably because progesterone exposure helped prolong those pregnancies. So we're very confident in the safety. We also have a small study that was carried out by Dr. Mitchell Crennan, who is actually a opponent of abortion pill reversal and has stated that himself and has stated that he wants to disprove it. Well, he conducted a randomized controlled trial that we would never conduct because he did have a placebo arm, but he did give women mifepristone, and then 24 hours later started progesterone in half the group and the other half he gave placebo. And it was found there that the study was stopped early after only 12 patients were enrolled because of, quote, safety concerns. However, when you look at what happened with the 3 patients of interest, one of them was in the progesterone group. She had what they called brisk bleeding, went to the emergency room. However, in the emergency room, she was just declared to have a completed abortion, required no treatment whatsoever, did not need to be in the emergency room. 2 other women who were in the placebo group, who only got mifepristone, did not get progesterone. Well, both of them needed emergency D&C, suction aspiration abortions, and one of them needed blood transfusions. So the 2 that required emergency treatment because of their mifepristone were in the placebo group. So really this suggested that only taking mifepristone by itself was dangerous. Taking mifepristone with progesterone, i.e. abortion pill reversal, was not dangerous.
Yes, and you mentioned also that study. So in his progesterone group, he had an 80% success rate. So the 5 evaluable patients that received progesterone, 4 out of the 5 had a fetus with a heartbeat at 2 weeks after ingesting the mifeprex. So what he proved was that abortion pill reversal, the provision of progesterone, works to mitigate the effects of mifeprex. The other thing that was very interesting about that study, I think it's worthwhile talking about, is that the conclusions were APR is dangerous, but they had nothing to do with the data. So here's a glaring example of sometimes you have to read past the conclusions and actually read the data to know what the study actually says. So thank you for bringing up that Crennan study. It's a very important study. Now, I've got another question for you. For those who are interested in getting involved with abortion pill reversal, who is allowed to provide abortion pill reversal, which is progesterone?
So really any physician or nurse practitioner, physician assistant, or midwife who is accustomed to, trained in, and competent in taking care of women in their first trimester of pregnancy, particularly women who have threatened miscarriages, threatened abortions, would be capable of taking care of these women, because really the treatment is very, very similar as far as the follow-up, the monitoring, and the treatment with progesterone, actually. So anybody who is comfortable taking care of those patients, that patient group, would be very well capable of taking care of a woman who sought abortion pill reversal.
Well, how can medical professionals who want to provide it get started?
So if you're interested in joining the Abortion Pill Reversal Network, there is a website I'll tell you about. It's aprnworldwide.com. That is the actual portal to register. If you just want information, you can send an email to info@apr.life, L-I-F-E.
Okay. So great. And we also, Miriam will be providing that information to you all, I think in the chat, and certainly she can follow up. So if you missed that, link, we will provide that information to you. So you have all this huge amount of frank, inaccurate information. And other than joining and becoming an APR provider, what can we do to combat this just the spread of no-test telemedicine abortion pills, the spread of women getting these pills without informed consent, without appropriate follow-up? What can we do to combat the increasing push for mifeprex abortions?
I think we have to, first of all, realize and sort of rededicate ourselves as being physicians who are practicing medicine because we care about our patients, and we're going to put our patients' lives and livelihoods and health first behind any kind of agendas. And so that's, I think, what's taking the pro-abortion group off of the rails in just a severe way, really. They just are putting their agenda above everything else. And they are not concerned about the risks of these mail order and telemedicine abortions. And I'll go into that a little bit if we have time, and I think we do, because we have seen these risks cropping up already, and I'm sure they're going to proliferate as these abortions proliferate. One is these women often will get the medical abortions without an ultrasound. So without an ultrasound, there will be inaccurate dating. APLOG itself says that you should get an ultrasound to date a pregnancy because you can't trust an LMP. And so they're just throwing that out the window because of their agenda. And so with inaccurate dating, a woman who's too far along might take the mifepristone. Or on the other hand, a woman who maybe misread a pregnancy test and really isn't pregnant might take mifepristone unnecessarily. Secondly, of course, is the ultrasound is critical to rule out ectopic pregnancy. And that is 10% of all pregnancies these days may be ectopic pregnancies. And so a woman taking mifepristone, which is contraindicated in an ectopic pregnancy, could be putting herself at risk because she'd be delaying medical care. When she notices bleeding, she may think that it's a normal part of the medical abortion, but actually it could be a tubal rupture. So are we going to wait till women start dying in their bathrooms because they're fooled into thinking they have intrauterine pregnancies because they didn't get ultrasounds? That's putting an agenda before our patients, right? The other risks are that these women are not going to be checked for their Rh status. And we know that during an abortion that there can be mixing of blood, and the woman can get isoimmunization, can get sensitized if she's Rh negative and carrying an Rh positive embryo or fetus. And so that could doom her to multiple preterm deliveries and stillbirths down the line with multiple pregnancies because the agenda was put before the medical treatment, what's best for the patient. And then there are the social risks. So what's going to happen there and what's already happening is that men will be getting mifepristone online by pretending they're women. Then they will surreptitiously give the mifepristone, or they will force their partners to take mifepristone. This will become the tool of sex traffickers, of rapists, and of child molesters. So we're going to see that women are going to be coerced and that they're going to be actually losing their reproductive freedom. All this in the name of, quote, reproductive freedom. We're going to see all of these social ills and women become even bigger victims than they are already by the medical abortion complex. So we have to, first of all, be informed about all this. Secondly, be informed about the availability of abortion pill reversal. And then we have to become advocates like we always are for the well-being, the health, and the lives of our patients. And so it's good that we can have signs in our offices. There are even stickers you can get from Abortion Pill Rescue Network. You can go to the info@apr.life. You can get stickers that you can put in bathrooms, stickers that you can put on your car or in your offices that tell women, hey, there's an option here that you can reverse this medical abortion. And we also have to be advocates and try to stop the telemedicine abortions, stop the mail order abortions, because these people who are spreading this, they're going to be breaking laws. They're going to be breaking federal laws by crossing state lines. They'll be breaking some state laws. They're just not going to be practicing good medicine, if they're even practicing medicine at all. So it's going to be up to us to raise these issues, because unfortunately, in the current administration, the Department of Justice is not going to be very enthusiastic about prosecuting them. But the more there's an outcry from any kind of organized medicine, especially organized pro-life medicine, it's going to be harder for them to turn a blind eye to these abuses. So it's our job really to make this known. So just like we would if there's anything else being done to our patients that's nefarious, so that people will take notice. And people do respect us, and they respect us as pro-life medical leaders. So we have to make our voices heard.
Well, I think you covered some incredibly important territory there, from the risks to women to how we can actually do something to move the needle on this issue. So I'm going to take some comments from people, some questions. So the first comment, how is outcomes data being collected for chemical abortion and for APR? So I'm going to comment on the chemical abortion. The fact is there isn't outcomes data being collected on chemical abortion anywhere in the country. No one's tracking. It's the FDA stopped tracking this back in when they changed the REMS requirements. So there's no longer any information being collected anywhere about complications from chemical abortion. So go ahead for the APR question.
Okay. Heartbeat International is doing a great job of collecting data on the women who are coming through the network. So that's being collected now. And as far as future research, we already have some animal studies that have gone on and will continue by Dr. Stephen Samut at the Franciscan University with support from Steno Institute and others. So we're very excited about that. We also will have a study coming up very shortly utilizing data that Heartbeat International will be collecting in the future, as well as farther in the future, we're hoping to have a randomized control trial that will compare two different treatment groups, two active treatment groups of progesterone to see which group does better with which protocol.
Here's a question from what looks like a pregnancy care center. The question is it safe to advertise APR without having a doctor to refer to locally? How would you advise?
So you need to have a medical practitioner who can treat the patient. So, you could advertise, but you have to have a way to refer. You have to know your closest practitioner, and you can find that through the APR and APR network. So that would be the most important thing. And wherever you are in whatever area you're in, start talking to your pro-life doctors and really tell them that it's really their responsibility, that they have to step up. You're putting yourselves out there as the Pregnancy Resource Center. We physicians and other medical practitioners, we have to put ourselves out there too to provide the medical expertise, because it's a team effort, and the Pregnancy Resource Center provides a lot of the emotional support, the counseling, the material support, filling in all the gaps, while the physician or the other medical practitioner has to be the one who makes the medical judgments and prescribes the progesterone. So we really need all of it to make it work, so that a physician's not on the phone all the time or getting pages all the time. But you can't have that piece without the physician. So I think reaching out to your pro-life leaders and your pro-life physicians and others is going to be what it takes in your community.
Great. So following up on the previous question about outcomes data for APR, is there a national registry that a APR provider could feed their information into? Is there a way, if they're not part of the Heartbeat network, is there a way that they can provide information to the Heartbeat network?
That's a great question. We haven't started a registry yet per se, but that's really a good idea to see if maybe we could have that information, that data come into the Heartbeat system. So that's something that I'm going to put on my list to look into. I think that's a great suggestion.
Here's another question. What medical liability coverage is available for medical professionals that volunteer to start or to join the Abortion Pill Reversal Network?
So for the physician or other medical practitioner, it's really the regular malpractice insurance coverage that would cover you for treating, let's say, a threatened abortion in the office. So if you have that, you will be covered. If you don't have any coverage at all, then you'll have to start getting medical malpractice coverage and maybe see if your Pregnancy Resource Center can provide that for you. The Pregnancy Resource Centers themselves, the pregnancy help centers, they often will need a special coverage, and that is provided by a couple of different companies, including Williams and Kemperer, as well as Patriot Insurance agencies. These are two agencies that have been very active and supportive of APR, and have very willingly designed special coverage that can cover the pregnancy help centers for that.
Great. Well, here's another question. What adverse events have you seen, adverse reactions or unwanted side effects, have you seen in your experience, both personally and with the Abortion Pill Reversal Network? What have you seen with abortion pill reversal, with the use of progesterone?
So really, the only I wouldn't call it an untoward consequence, but just there are failures sometimes where women start the progesterone and it's not 100% perfect. Like I said, with our best protocol, 68%. So then we see that just simply a completion of the medical abortion. We see bleeding and cramping, but we haven't seen excessive bleeding or any one needing transfusions. As far as less serious side effects, we've seen nausea and vomiting, as well as somnolence. Progesterone can cause somnolence. We have seen a few instances of mild mood perturbations, because we know that progesterone does have an effect on the mood. Most of the time, it's a slight elevation of the mood that's usually not very troublesome. Sometimes it can cause a little bit of a depressed mood. But again, you wouldn't know if that's from going through a medical abortion and trying to reverse it or not. The psychological dynamics there are quite large. Some women also have experienced GERD symptoms, heartburn and the like, because progesterone is a smooth muscle relaxant. And a few have also complained of worsening of varicose vein pain, again, because of the relaxation of smooth muscle. We have not seen any reports of any deep venous thromboses of women taking progesterone for this, however.
Great, good to know. So here's a technical question for you. Do you recommend checking progesterone levels before stopping the progesterone? That is there evidence for checking the progesterone levels at first contact and then every few weeks, like the NAPRO protocols?
So, we leave that as optional. I don't recommend necessarily checking levels before you start, as long as you're confident that the preborn baby is viable. I don't recommend checking them because you're going to be giving the progesterone regardless. What I do in my own practice, and what some doctors who have NAPRO technology training do, is at the end of the first trimester, or if it was late in the first trimester, after 2 weeks of treatment, then I will check a trough progesterone level, have the woman skip a dose and check a level, and then decide if I'm going to continue the progesterone, maybe following the NAPRO technology protocols promulgated by Dr. Thomas Hilgers. But we don't really have any data supporting that. So that is optional for doctors who want to do that. Otherwise, we recommend if you want to just stop at the end of the first trimester with the progesterone.
Okay. So another technical question for you. I don't think we went into this, but what form and what route of progesterone is given right now?
Right now, the predominant route that we're using is oral, and we're using what's called the high-dose oral protocol. And that's 400 milligrams twice a day for 3 days, and then 400 milligrams at night until the end of the first trimester, or for a minimum of 2 weeks. Now, we have good data for that from our large case series. Now, when I made a trip to Switzerland a couple of years ago, and they were using much higher doses of progesterone, primarily because they were still using mifepristone 600 milligrams, which was the old dose.
Yes.
Nonetheless, women were tolerating the progesterone at high doses very, very well. So when I got back and speaking to other physicians, I actually myself, I've started using a bit higher dose now, 600 milligrams twice a day for 2 days, then 400 milligrams twice a day for 2 days, and then 400 milligrams at night. So a little bit higher at the beginning, just to get them a little boost. And the women I've treated have tolerated that very, very well with no complications, no problems at all. So there are some doctors doing that. Some physicians are using the vaginal protocol, which is the high doses, but given vaginally, mostly because they're used to using vaginal progesterone. And you can give the micronized progesterone capsules vaginally, and they will dissolve and be absorbed very well. Our data for that are not very good, however, so we're waiting to conduct more studies before we formally recommend that. But certainly, if some doctors are comfortable with using vaginal progesterone and they have had good results, I certainly wouldn't try to dissuade them. The last route that's becoming less popular now is intramuscular progesterone. We started with that route, assuming that intramuscular progesterone would be more successful in reversing mifepristone. The data that we collected were that it's about equal, 64% compared to 68% for high-dose oral. We know that injections hurt a bit more, and so that's one of the reasons why we're not using them. Also because the off-the-shelf progesterone for injection is 50 milligrams per ml, so you have to give a 4 ml injection or 2 ml at each site, so that's quite a bit to burden a woman. You can get 100 milligrams per 5 ml per ml progesterone, but it's compounded. It's getting more difficult to get compounded progesterone nowadays because of the more stringent laws in many states, so it's just becoming tougher and tougher to get that. But certainly if a woman has a peanut allergy, we would suggest trying to get progesterone in oil, not in peanut oil, of course, in order to avoid that peanut exposure, because all of the oral micronized progesterone off the shelf is in peanut oil. You could also have capsules compounded in an oil other than peanut oil, such as sesame seed oil, and that would be another way to avoid injections. But if you happen to have the injection on hand, you don't want to wait for the compounding pharmacy to make up the peanut oil-free progesterone. You could start that in a pinch until you get the compounded non-peanut oil capsules.
Great. Well, since we're talking about this, I think it's going to be important to say a word or two about the difference between progestins and progesterone. So, for example, ACOG in their practice bulletin on medication abortion is speaking out of both sides of its mouth when it says that there's no evidence for the effectiveness of progesterone reversal, and yet later in the same document, they say don't give Depo-Provera at the same time as Mifeprex because of the increase in ongoing pregnancies. So I know that progestins are not near as effective and have multiple other side effects than natural progesterone, but can you elaborate on what is in Depo-Provera as opposed to what is in natural progesterone?
Sure. So Depo-Provera contains methylprogesterone acetate, medroxyprogesterone acetate, which is essentially it's a progesterone analog, and that's what a progestin is. It's any of a number of different compounds that have progesterone actions. And so that means that they will latch onto the progesterone receptor, usually with pretty good affinity, and medroxyprogesterone acetate has very good affinity for the progesterone receptor. The reason we don't use it, of course, is because it has other effects, including androgen effects, which can cause changes in the development of genitalia. So it would make sense that, though, if you did give medroxyprogesterone acetate or other progestins, that because they're progestins or because they bind to the progesterone receptor and are agonists, that they could also outcompete the mifepristone. And that's why APLOG gives that caveat there, not to give the depot medroxyprogesterone acetate shot at the time of mifepristone, because it would be fighting against the mifepristone, no doubt.
Yeah, that's the ACOG practice bulletin. So switching gears just a little bit, what's the latest time that you can give abortion pill reversal? So she takes the first drug, Mifeprex. The clock starts ticking. What's the latest time that progesterone supplementation would be effective?
Well, we have data on women out 72 hours after mifepristone ingestion taking progesterone and having successful reversal. So that's the most that we've documented. However, we have had case reports and even in my own clinical experience where women have been beyond that 72-hour window. What I've done there is I've checked an ultrasound. If viability is confirmed, then I go ahead and start progesterone anyway, because I think there's a certain amount of recovery that has to take place, because even if embryonic or fetal death has not occurred, we do know that sometimes there is some separation and that we do have subchorionic hematoma formation. And we think that extra progesterone levels allows that recovery. We also know that progesterone has an inhibitory effect on the corpus luteum. And so therefore, by inhibiting the corpus luteum, the natural progesterone production will be diminished. And so there may be a lag of that recovery, even if the preborn baby did survive the first onslaught of the mifepristone. So we think for those reasons, if post 72 hours, if you do have a viable embryo or fetus, that you do give progesterone nonetheless.
Thanks. Okay, we're going to shift gears a little bit because we've got several questions that I'm going to kind of combine into one question. It's about malpractice concerns and suits. So one participant writes in to say, my organization has declined participation in APR because of the threat of a lawsuit if a baby is born with birth defects. But that occurs in 2% of all routine pregnancies. So can you help us with what we should do in this case?
Sure, and just to kind of frame the answer, I have, in talking to different hospitals and healthcare systems and trying to get more involved with APR, that really is a common misconception and a common fear. And of course, many of these health systems are run by people who listen to lawyers more than they listen to doctors, and certainly to pro-life doctors. And so the lawyers, their job, of course, is to give maximum protection, prophylaxis against lawsuits. But the matter is, there has never been a lawsuit filed against any APR practitioner ever. And so it just hasn't happened. So why are they so scared of something that, first of all, has never happened? Number two, there's no evidence of birth defects with abortion pill reversal. And in fact, there's good evidence in the medical literature that neither mifepristone nor progesterone by themselves or together cause birth defects. And our data with the largest case series so far shows that the birth defect rate was about the same as the general birth defect rate in the general population. So there's no evidence to support that fear. And so that fear is an unsupported fear. It becomes a paranoia. So we need to break that paranoia and come to them with the data, and show them that there are over 1,000 doctors in this APR network now, that they're successfully doing. None of them have been sued. That this is now international. That there's been abortion pill reversal now probably in about 20 different foreign countries, all 50 states. So this is spreading all around. They might as well get on the train, start helping these women. And there's really no legal concern other than the regular precautions that you take when you're treating any woman who's pregnant and who's having a threatened miscarriage.
Yes, that's right. Great. That is really good news. Can you address the mental health aspects of the APR experience, including before and during and postpartum, as well as the mental health of reversal failures?
Sure. So first of all, we don't have any good data yet on mental health outcomes through all of this, and something that I think is a great area for research, and the Steno Institute is very interested in trying to support that kind of research. So if anybody out there is interested, please contact us at stenoinstitute.org. But anecdotally, speaking to practitioners all over the country, talking to the leaders of abortion pill reversal network at Heartbeat International, in my own experience anecdotally, is that this is a psychologically very tumultuous time, because first of all, women, when they choose abortion, the data do show that women do often have regrets, and there's a lot of data there, a lot of good research done by Dr. Priscilla Coleman and others that shows that women often do have regrets. And so they come into this, first of all, having a lot of regrets and having a lot of indecision, and oftentimes feeling like they're forced into the abortion. And then we introduce the concept and offer them abortion pill reversal, give them all the information, give them informed consent. And in fact, I will say parenthetically that our website, or the Abortion Pill Reversal Network website, abortionpillreversal.com, has more information on the risks of medical abortion itself compared to the typical Planned Parenthood website. So we give them much better information, first of all, about medical abortion itself, and then, of course, about reversal and the benefits and any possible side effects. And so we really give them very, very good informed consent, much better than they get in any of the abortion centers. It's certainly much better than they're going to get online when they do these mail order and telemedicine abortions. So that's the first part. And the second part is that when they make that decision for abortion pill reversal, well, psychologically, they're still having some cognitive dissonance because they're still feeling all the pressures, either from coercion from their partners, from parents, from family members, jobs, all of this. And think about the subtle coercion. I'm going a little bit down a rabbit hole, but think about the subtle coercion of a company like Amazon that now says, we'll pay for you to fly to another state to have your abortion. We'll pay for your hotel room, everything else. We'll pay for everything you need to have an abortion. What does that tell a woman? That you're only good if you can be on that assembly line, on the job, driving that truck. You're no good to us if you're pregnant. And so we're going to do whatever we can to keep you on the job, to keep you working. I mean, this is like coal mine mentality, if you think about it, that you have this, quote, medical coverage set up only to keep the laborer going, to keep their nose to the grindstone. No better than the times when we had the coal mines and they had just the doctors, the company doctors there who would just try to keep the workers in the coal mines. But anyway, back to this. But there's that's coercion, subtle and not so subtle. And so they will have this cognitive dissonance, and they sometimes go back and forth, and they have, second thoughts about even reversal. And we've had women who've disappeared, and suddenly we don't hear from them. But then they miraculously reappear when they're into the third trimester. Hey, I'm doing great. Or here's a picture of my baby, because they have a lot of psychological of turmoil. And so that's why supportive counseling is so important, and that's why the pregnancy help centers are so important, to have that counselor walking, journeying with them. They need that mentor. They need someone to whom they can talk to. They need someone who can support them. So very critically important, and I think this is an area that's really going to be great for research in the future of how we best give these women support. Because abortion pill reversal is not about coercing. It's not about arm twisting. It's about being there for them and giving them that option, giving them that choice, and then supporting them. So when a woman decides she no longer wants to reverse, and even if she goes back and has a surgical abortion or takes mifepristone a second time or takes misoprostol, those counselors are still with her and will still receive her and still love her. And that's the difference between us and the other side, where once they have the cash in hand, the abortion's done, they really don't care about them anymore unless they want to come for more birth control pills or for the next abortion.
Wow, that's really important information, George. Thank you. Here's another technical question. Is there a dosage adjustment for twins? I treated 2 twin pregnancies per protocol, but both pregnancies had no heartbeat on the next day ultrasound.
So that's a great question. Right now, we do not have any data on that. What we do know, however, is that twin gestations, medical abortions are not as successful. And you think about it, it makes sense, because the twin gestations generally have higher progesterone levels, and they have more progesterone receptors, but they give the same dose nonetheless. They give the 200 milligrams. So actually, we feel that, anecdotally, that our success rates are better with twin gestations. We have not increased the dose for them, for the twin gestations. But if you want to, it makes sense that it would work better, and that the woman's physiology would be more accepting of higher doses, because she's already used to having higher progesterones anyway. So I certainly would not fault that approach. Right now I don't have data to support that it's necessary, however.
Yeah, okay, great. Here's another question. I've heard that sometimes it gets tricky to make sure that an APR consulting pregnancy center and the prescribing doctor connect appropriately and then collaborate to care for the patient. So is there a way to make sure that that collaboration happens? Is there some mechanism of increasing collaboration between the treating physician who's doing the prenatal care and the pregnancy care center who may be doing the supportive care that you talked about?
Yes, absolutely. I think, that just is going to be good communication. Just like with any medical care, you always want what we call warm handoffs, good information passed on, preferably verbal conversations and not just records that may or may not get there. And then follow-up. Yeah, so I would encourage you, pregnancy help centers, you counselors, to develop good relationships with the treating physicians and give them updates. And of course, you're going to want to be sensitive that a busy physician or other medical practitioner may not always have time to take a phone call. And maybe after that initial phone call, just ask, how would you like to communicate? How can we do it in a secure way? Do you have secure email? Can we do it by fax? And of course, you get the patient's permission to do that, so that we're staying clear of any HIPAA violations.
Yeah, great. There's a question here I think you already answered, but can you, somebody also asked, can you tell us about international APR providers? There's an interest in Ontario and in Cuba.
So yes, I don't know if we have anybody in Cuba and Ontario. We do have some APR practitioners in Canada. In fact, Canada has a very large, what I'd call a resistance movement, because those pro-life physicians in Canada are being persecuted by the governmental bodies. As you may know, in Canada, all licensure and your ability to practice medicine depends on the medical governing body, not some independent board. So there it's much more, the power is much more centralized. And so it's much easier to persecute physicians there. And they have persecuted them, but they're fighting back, and they have won the ability to treat women who want to reverse their medical abortions with APR. So they've won a good victory there. They really have been quite courageous. Physicians in other countries, in the UK, specifically in Ireland, have also been great beacons of hope and great role models for us here, because I'm sure we're going to see more persecution as the pro-abortion forces see that they're losing traction and losing ground to us. But as far as if you want to know, particularly in those countries, I would recommend that you email info@apr.life, and they can give you some information about that.
Well, along those lines, here's another question. What do you do? Can you comment about the strangulation that Google has on advertisements, especially about APR?
Yeah, so I think, that's really a tough one. I think, we can certainly add our voices to those who feel that Google has an unfair monopoly. So if Google is going to be such a predominant force in the cyber world, and this goes as well for Facebook and Twitter, that they need to be open platforms and allow free speech. If they're going to be a purely proprietary entity that picks and chooses what they want to support, which, a company has a right to do that, well, then they should not be given these certain freedoms that they've been given, and limitations and protections from lawsuits. So they're playing it both ways. So I think we have to demand and use our civic influence in order to protect from that. Otherwise, we have to be creative until the changes come, or if they ever do come, and use other platforms that allow us to advertise without that censorship. And of course, they have a smaller base, but again, we, as a small persecuted pro-life group, we have to be very creative and inventive, and we have to use different avenues, different sources of information. We can't rely on the conduits that are allied with the pro-abortion and anti-life forces, because if we depend on them, then we will succumb to their censorship.
Very good. Another question here. What's up with ACOG? Why aren't they reading the medical literature? Do you have some insight into why they are fighting so hard against what is obviously written and in front of their nose?
Sure. Well, I think, ACOG has become a very politicized organization. And those of you who are members of ACOG, I'm not, but those of you are know that, going way back, when ACOG used to be a pro-life organization, and ACOG used to be a pro-life organization, and then they quickly turned to become a pro-abortion organization. And it happened very, very quickly. And it wasn't a grassroots effort that rose from the bottom up. Rather, it was that pro-abortion advocates placed people in leadership in ACOG and advocated for them and got them elected, and encouraged these pro-abortion doctors and others to rise in the ranks very quickly of ACOG. And then they started writing these position documents and changing their official positions so that they very quickly became a pro-life organization. And then from there—
Pro-abortion, yeah.
Pro-abortion. Sorry, organization, yeah. Thank you. And from there, they started strengthening their alliances with Planned Parenthood and with other forces of abortion. So they formed this medical abortion complex that now is very well refined and is very strong allegiances and alliances. And you see that people who write the ACOG bulletins, such as Dr. Mitchell Crennan, Dr. Daniel Grossman, also are on the boards of different groups like or teacher at like the Bixby Institute at UCSF, which is a promoter of international abortion, or they're consultants with Danko Medical Laboratories, which produces mifepristone. So you see this complex web of people who are profiting from abortion right and left, and they all are supporting each other. So it becomes enshrined as one of their primary objectives of their agenda. If you look at the ACOG agenda, if you had a secret list of what their priority list is, it would be abortion number 1, 2, and 3, probably, the way they act. And so that's why they are fighting abortion pill reversal tooth and nail, because again, it questions their narrative that abortion is a great good. How can it be a great good for all women if there are so many women now who want to reverse their medical abortion, so many women who realize, no, I want to stop this, I want to save my baby. So it flies in their face of their narrative. So that's why they want to suppress it at all costs.
Well, and I have to say too, just in facing off with ACOG in different legal arenas, the narrative is that women are 100% sure when they walk into the abortion clinic, so there's no need for informed consent. There's no need to talk about risks because there's absolutely no ambivalence when the reality is, and abortion pill reversal proves this, women are vulnerable and they are susceptible to marketing techniques, which is very, very threatening for the pro-abortion narrative that we don't need to worry about giving them appropriate informed consent. So I think the fact that APR exists threatens many, many narratives. And just to underline what you've talked about, if anybody doubts that what George is saying is true, Google ACOG evolution of abortion policy. ACOG's very proud of the fact that they became pro-abortion from a top-down initiative that never, ever consulted the membership, and they still haven't to this day. So let me see if we could pull in a few more questions in the last 4 minutes here. So from a woman's initial phone call for APR until a prescription goes out, in the US, what's the average time turnaround?
Well, right now, the vast majority of women going through the abortion pill reversal network are starting their progesterone within 24 hours. So probably 80–90%. So we're really, really happy about that. And there's a large percentage of them who are actually getting started within 12 hours. So we're seeing very, very good turnaround times and getting women started on progesterone. So that's great. And where there are 24-hour pharmacies, that's really golden. And many women do live in areas with 24-hour pharmacies. So it's wonderful. And as our network grows, then it becomes much easier to contact the doctor who's very close to her, very local, without having to scramble around, make multiple phone calls. So turnaround times are great right now and getting even better. And it's interesting, just because most of our turnaround times are 24 hours or less, that the Crennan study, they actually, for their study that to which I referred to earlier, they chose as the starting point for giving the first progesterone or placebo dose at 24 hours after mifepristone injection. So that study actually is, in the long run, is going to help us so much more. They also used our 25% survival rate if nothing else is done, and our 68% survival with the best protocols for their pretrial power calculations for their statistical analysis pretrial. So they cited us a lot in their study, and we're really grateful for that. That adds legitimacy, if nothing else, but it really helps our cause.
Okay. Well, we're heading into the last 2 minutes here, and I want to take a little bit of time for wrap up. So I think that's going to be the last question. Let me just look through here and see if there's anything different that we haven't faced. I know we have tons more questions, but I tried to group the questions into those that were the most often asked. So as we wrap up, just a quick note, Dr. Delgado cited a good number of studies, and links to these studies will be available in the resources sheet that's about to be sent in the chat. In addition, feel free to check out our Mythbusters video about APR. It's on our website, and if you go to our AppLog home site and you look at the top bar, you'll see abortion pill reversal, a whole tab by itself that has our videos and has questions and answers, frequently asked questions about becoming an APR provider. So please check that out, and it may answer a lot of questions that you already have. I want to really thank you for coming. It was our hope that this would be helpful to all of you as you consider how to navigate this current moment and how to best support your patients. We understand it can feel very lonely to be a pro-life physician, and especially when you're in training, but you are not alone. And we hope this helps you to know that you're not alone. APLUG is here for you. And the more than 3/4 of OBGYNs who do not perform abortions, that's actually between 85 and 93% of OB-GYNs don't perform abortions. But we're here for you, and we would encourage you to consider joining APLUG as a member. We can help you, and we can sure use your voice, amplifying our voice. So to become a member, go to www.aaplog.org. And we're hoping to do more of these in the future, so please let us know if this was helpful to you. You'll have an opportunity to fill out a survey that we'll send in a follow-up email. We also encourage you strongly to register for the Matthew Bulfin Educational Conference, which will be held from February 10th through 12th, 2023 in Tucson, Arizona. It's going to be a fabulous conference, the 50-year anniversary of APLOG, and Roe versus Wade is now history. So couldn't be more important things to celebrate. Further details and the registration, which is now open, can be found at conference.aaplog.org. You can also check out our 4-part podcast series, the Post-Roe Review, the last episode of which just came out a couple weeks ago. It offers a variety of insights for pro-life advocates in the post-Roe era. Thank you very much for coming and attending, and we hope to see you again with our next podcast.